We'll move on to the next presenter, Dr. Vinuta.
Good morning, everybody. I'm Dr. Vinuta from JSS Hospital, Mysore. Today, I'm going to speak about the profile and outcome of patients admitted to obstetric ICU in a tertiary care center. Management of critically ill patients is a really challenging one. India contributes to almost 15% of global maternal death. As per SRS data of 2014, maternal mortality ratio is 130 per 1 lakh live births. For every maternal death, there is about 18 morbidities. The major causes of complications still remains the same triad: the postpartum hemorrhage, sepsis, and pregnancy-induced hypertension. The incidence of obstetric ICU admissions in developed countries is 2 to 4 per thousand, whereas in developing countries like India, it varies from 2 to 13.6 per thousand deliveries. Admission to obstetric ICU is an objective marker of severe maternal morbidity. Understanding the epidemiology of severe obstetric morbidity and near-miss events is crucial to improve maternal outcomes. The objective of my study was to evaluate the causes of obstetric ICU admissions, interventions required, course and outcome of all critically ill patients admitted to ICU. Study was conducted in JSS Medical College during the period of November 2016 to January 2018. It was a prospective observational study after getting approval from the Institutional Ethical Committee. We included all the pregnant patients admitted to ICU either due to obstetric or comorbid conditions. Exclusion criteria were those with poisoning, RTA, and any other medico-legal cause, and those patients expired within 4 hours of admission. The data collected include basic demographic data, obstetric and medical history, status before admission, after admission, course in the ICU, treatment taken, and specific interventions done. Statistical analysis was done by Microsoft SL and SPSS version 20. During my period, there was 7,688 total number of obstetric admissions, out of which 482 were admitted to HDU. 51 admissions to obstetric ICU, of which 30 were direct admissions to ICU, whereas 21 were shifted from HDU to ICU. Of the 51 patients, 44 survived and 7 did not. Coming to the demographic profile, of 51 patients, the mean age of the patients were 25 years. Around 39% were literate, 84% were from the rural background, and only 34% received proper antenatal care, and almost 70% of my patients had to travel for more than 50 kilometers to reach tertiary care center. When we looked at the obstetric and non-obstetric complications, around 86% of the patients still had obstetric complications rather than the other medical and surgical problems. Of 86%, pregnancy-induced hypertension, obstetrical hemorrhage, DIC, sepsis, HELP syndrome, and pericardial cardiomyopathy were noted. This is the same thing I've depicted in pie chart. And when we looked at the non-obstetric complications, RHD, pulmonary embolism, jaundice, hemorrhage, dengue hemorrhagic shock were noted. When we compared about the survivors and the non-survivors, the mean gestational age of survivors was 32 weeks. They stayed for ICU in 5 days and hospital for 13 days. 18 underwent cesarean, 20 underwent normal deliveries. Around 3 to 4 pins of blood transfusion was done. 7 required ventilatory support, 21 required hemodynamic support, 4 had to undergo dialysis, and fetal mortality was around 6 when compared to that of the non-survivors. ICU admission rate during my study was 0.6. The common indications of admissions in the present study were hypertensive disorders of pregnancy, postpartum hemorrhage, and sepsis. ICU mortality rate was 14%. Of 44 who survived, 7 had end organ failures. So coming on to the discussion, the lack of proper antenatal care, poor socioeconomic background, the longer distance from the healthcare facility predicted poor outcomes. Majority of the admissions were postpartum. Higher number of causes of ruptured ectopic was being noted when compared to the other studies. The lower ICU admission rate and mortality rate compared to other studies attributes to our well-functioning HDU. The cases in HDU were properly monitored intensively and transferred to obstetric ICU as per our protocol. In our own study, when we compared the statistics before the development of HDU and after development of HDU, the incidence of maternal mortality came down to 0.9% during my study period. To conclude, introduction of obstetric ICU and management of critically ill patients involving multidisciplinary approach has brought down the incidence of maternal mortality. It calls for early recognition of complications and appropriate referral, which leads to better outcome. Life doesn't come with a manual, it comes with mother. So the responsibility is on us to take care of it. Thank you.